Okay, got a couple of announcements before we get started. Don't forget that the lab report is due in lab this week. Okay, I brought it up many times, just a reminder. Also, this week in lab is the last day of lab. We have the case study, which you'll get in lab. There's 15 questions worth 2 points apiece. Bring your computers, I want you to, or your iPads or whatever, notepads, whatever you've got, or smartphones will work, because there's going to be 15 questions. Bless you. And I'm going to ask you, I say, and the questions I have in the handout, I said, put these questions right into the search engine. It can't be simpler. And work together as a group to answer the questions. And then we'll go over it, okay, as a class, so agreed upon. And then you turn that case study in at the end of lab. And it's going to take me a while to grade it, because then I'm also going to have to start grading lab reports. So give me a couple of weeks on that. But that will act as an extra lab quiz so that you can drop your lowest lab quiz score. All right. So any questions about that? We're getting there. All right. Looking at the calendar. I'm always looking at the calendar. Here, hold on. So we are April 4th. Yay, April. And the last day of class is the 25th. And yes, I will be having class on the 25th because we still have to cover. We're getting kidney physiology started today. We'll get through it this week. And then next week, immune physiology. And then we'll end it with my favorite topic, male, female reproductive biology, because that's my PhD. All right, reproductive physiology. All right, so we got 3 chapters left. And those will be the 3 chapters that'll be on the final exam. And someone emailed me asking, is our final exam as it says on the syllabus? It is. It is Friday, April 29th at 8:30. Do I have that right date? Calendar again. So yeah, so our last day of class is here. That's our exam at 8:30. It's going to be in this room unless something changes. All right. 8:30, not 9:30. But it will still be the typical exam, 50 questions, multiple choice that you're used to. I'm not going to change anything up on that. Okay. But we're getting there. Yeah. Okay. What else? What else do I have? Also, so that donation that we have, that I have for those 3 points, I announced this on Friday, but I'll announce it again. I changed the date to the 12th, which is next Tuesday. And really, I'm going to be picking up the boxes that day from wherever they are around campus, because someone from Black Creek is actually coming to give a talk that afternoon. And I figured they're on campus. I could give them all the supplies we got. And so it works out. So I've moved it from the 20th to the 12th. All right. The other thing is, and I mentioned this on Friday, but if you weren't here, on the 22nd, if you look at the university calendar, their pre-vet club is hosting the Pause for Pause event. Literally, Florence Area Humane Society is bringing puppies onto campus for you to cuddle with. All right, from 12 to 3 under a tent outside the university center. We've done it before COVID, and it is such a great stress relief. And faculty are going to be there too, because who doesn't want to cuddle puppies, right? So that's coming up too. So it's not all stress. Okay, some things can allow you to de-stress. All right, any questions about all those announcements? Okay, all right, so let me back out of some of these. I need them all up. Okay. This is always in the way. Does anyone even care if I post these online? It's really for people who can't be here, but it is on the syllabus, links to the YouTube videos. If you ever want to listen to what I said again or go over something again, it's all online there for you. It's just a nice backup. Not for you to skip class, because I always go over stuff in class that, you know, sometimes aren't on the PowerPoint. So we all survived the kidney lab last week. It wasn't that bad. Pee party. It was not that bad, but so some of this is going to be familiar. We talked about ADH and the secretion and the inhibition of ADH secretion. So we're going to get right into kidney function, kidney physiology, by talking about the ways that the urinary system regulates blood volume and blood pressure, because it is the main system that does it. It's the long fix. It's responding to hormones. All right, the quick fix we know, because that's coming up on our exam on Friday. The medulla, the baroreceptors, the medulla, and either increase heart rate and vasoconstrict or decrease heart rate and vasodilate. That's a quick fix. All right, so I'm repeating myself because you've got an exam this Friday. So blood volume is controlled by your kidneys. How much do your kidneys retain in terms of the water component of your blood? And that goes back into your bloodstream versus how much do they excrete in your urine? All right. And the hormones that we've talked about that affect that. So let's recap as a quick little way to review for Friday, because I'm going to be asking these hormonal long fixes to blood pressure. So what is something we covered in lab that can affect blood volume and blood pressure, but that is a side effect? Its main role is to regulate blood osmolarity. So what was that one we covered in lab? I just said it. 3-letter acronym. Oh, come on, pen. This is giving you time to think about it. I'll help you out. ADH. All right. People who drank the saline solution at time 30, they had ADH secretion. What did ADH cause to happen for those of you who drink the salt? Did your urine output go up or down? It went down. So you will increase water retention and your urine output goes down. Now I'm going to leave this for you to review, but if you're retaining water because of ADH, that water goes back into your circulatory system, back into your blood vessels. And its function is to decrease blood osmolarity by diluting the salts that are in your blood. That's how it worked. Yes, when you retain water, your blood volume and blood pressure will go up, but that wasn't the goal for ADH. A change in blood pressure outside the normal range is not a stimulus for ADH secretion. A change in blood osmolarity is. So when I have that exam and I ask you which of these things would correct blood osmolarity, it ain't going to be renin release. It's not going to be ANP release from the heart. Those are secreted to fix blood pressure. The only one that's secreted to fix blood osmolarity is ADH. All right. Now give me another hormone. I just said it. Something from the heart. What's another hormone? Another 3-letter acronym that begins with the A, and I just said it. ANP. ANP is released from the heart. It will increase urine filtration. So you pee more. If you're peeing out body water, what's that doing to your blood volume? You're losing body water out in your urine. What's happening to your blood volume? It goes down because you're peeing that water out. If your blood volume goes down, what happens to your blood pressure? It directly follows, it goes down. ANP is released from the heart when blood pressure is too high. And it causes you to pee out that body water and drops your blood pressure. Okay, what is another hormonal fix? It's not a 3-letter acronym. It's something that the JGA secretes if blood pressure coming into the kidneys is too low. That's the end of the long pathway. What starts it? Renin. Okay, ultimately leads to aldosterone. And what does aldosterone do? It's got the letters in it. Increased salt, then water retention. Because water doesn't go anywhere unless salt moves. So if you're retaining now water, your blood volume goes up and your blood pressure goes up. All right, because I'm definitely asking those questions. I already sent you the exam breakdown. Okay, so if this is gobbledygook for you, you need to go and study that. All right. Okay, so blood volume changes and that changes blood pressure. And we're going to talk about what something else the kidneys can do. It's going to be new, but it won't be on the exam, but it'd be another way that the body regulates blood volume and blood pressure, and the kidneys themselves are doing it outside of renin release. Okay, blood osmolarity. So we could have measured these in our urine, but it simply would have made the P-lab longer. But I could have had you measure for sodium, chloride, potassium, and calcium, things like that, but really sodium and chloride. All right. So depending on what the kidneys retain back into the bloodstream or excrete out in the urine, if your kidneys are getting rid of sodium, all right, salt, if you're peeing out salt, guess what's happening? Water's going to follow that salt out in your urine. All right. And so you're going to lose body water. That makes your blood volume, blood pressure go down. But it also changes your blood osmolarity because you're peeing out salts. Now, later end of the chapter, we're going to be talking about drugs like diuretics, which basically promote peeing out salt to pee out body water. And these diuretics function to decrease blood pressure in people who have hypertension. We've talked about a lot of ways to regulate high blood pressure because it's one of the big three. Right? We've talked about sodium and calcium channel blockers. We've talked about beta blockers. We've talked about ACE inhibitors. And now we'll get to diuretics. So there's so many drugs, so many ways to treat high blood pressure. So, but anyway, blood osmolarity, blood pH. Talk briefly about that. If you retain hydrogen ions, your blood acidity basically goes down, pH goes down. If you retain bicarbonate, which is what our kidneys do, they retain bicarbonate and they tend to pee out hydrogen ions. Your urine is a little bit acidic because you pee out the hydrogen ions, but you retain bicarbonate in your blood as a buffer. So that's what our kidneys do. And then endocrine functions, two of which we've covered elsewhere in this semester. We've covered renin, secreted by the JGA, which causes, and I can simply do this, ultimately aldosterone secretion. You retain salt, you retain water, blood volume goes up, blood pressure goes up. All right. We've talked about erythropoietin in the cardiovascular chapter. Your kidneys and your liver can produce this hormone, which makes your bone marrow produce red blood cells. And then not covered, this is a new one, calcitrol. And it's got the word Ca for calcium in it. So it increases calcium retention. So and your kidneys do so much. You could not survive 2 or 3 days without kidney function. If someone's kidney shut down, unless they go on dialysis, they're not going to make it. If someone comes in and you're doing the patient history, and especially if they got a blood pressure something problem or other problems, and they mention they haven't peed in 24 hours, you admit them, because not peeing in 24 hours is something that's got to be resolved, because it could be the kidneys have shut down or something else is going on. They could certainly be dehydrated or something like that, but kidneys not functioning, not producing. You're supposed to produce a certain amount of urine every single hour, nonstop, 24/7, 365. If your kidneys stop doing that, you admit that patient, because you got to resolve that, because in 2 or 3 days without kidney function, they're gone. All right. Okay. So don't memorize this, just some factoids. And we had this on a quiz. I think we had a quiz question. Your kidneys can filter 5.5 liters. Imagine what 5.5 liters is in every 40 minutes, the time that you're sitting here in this lecture. Your kidneys have basically filtered all of your blood volume. All right, that's pretty amazing. They're so efficient, you can live with one kidney just fine. It can do the job. So the renal artery brings blood to the kidneys to be filtered. And what happens is, we talked about filtration chapter 2, part 2, cell transport. It was a form of passive transport, filtration. Stuff gets filtered across a membrane based on fluid pressure, and that's what's happening with your kidneys. Blood comes into your kidneys. We're going to talk about nephrons. And remember the experiment where we had the dialysis tubing, and you put in starch and you put in glucose, starch being a big molecule, glucose being a simple molecule. And that bag is just like your kidney nephrons. It's got pores of a fixed size. Small things are going to make it through. Water certainly makes it through if there's a difference in concentration. But small things get through and big things don't. What made it outside the bag into the beaker water technically got filtered by the bag. That's what your kidney nephrons do. They take arterial blood and they filter it. And small things can get through. Glucose, small amino acids, lots of water, salts, all that stuff. And they get filtered. So when I say filtrate, that's what I mean here. So pretty much 99% of what gets filtered by your kidneys gets automatically reabsorbed, regardless of you're dehydrated or you're hydrated, regardless of hormones. The bulk of what goes through the kidneys is retained, because the body is like waste not, want not, especially things like glucose and things that are valuable for the body. They're going to hold on to that. Only about 1% might not be reabsorbed. It might get excreted in the urine, and it is influenced by hormones, right? Like renin, like ADH, things like that. Not renin, but aldosterone. Okay, so we had a question in the quiz last week on this. So what was oliguria? Was it increased urine output, decreased urine output? Which is it? Decreased urine output. Decreased urine output. Now, you're going to learn all kinds of normal values for men and women. And really, there is a difference between men and women, but it really scales just to body size. That's the important thing. But there is a normal range for people. All right. And if it's lower than that, you might want to figure out what's going on. It certainly could be you're just dehydrated, or maybe you ate something salty or something else. Now, polyuria, anyone know what that means? Increase urine output. Okay. It could be simply that you're very well hydrated. You just drank a party cup of water, like some of you in lab did. All right. And your body wants to get rid of that because it changes your blood osmolarity. So that's polyuria. Other things can cause it. I'm not going to get into all of them, but I'll just say in lab, you guys experience that if you drink a cup of water. Now, anuria, if it's got the A in front of it, what does the A usually mean? Absence. So no urine output. Okay. Bad. Okay. You got to find out what's going on in a patient that's not peeing, because the kidneys, first of all, let me tell you, and this is real. I know this from cats who have urinary stones, which I'll talk about urinary stones because it's very common in people too. In males that have a long, narrow urethra, if they form urinary stones and it blocks the urethra and they can't get that pee out. So I know it in cats. Someone call up and say, my cat's in the litter pan and he's yowling and he's straining and he's not producing anything. And I'm like, bring him in now. Okay, now. Emergency now. Same thing with a person. They're trying to go pee. They get a little blood out in their urine and it hurts and they're straining and they can't go. All right, it's an emergency. Not usually a problem in women because the urethra is wider and shorter, but in males, it can actually block the urine from leaving. Two things go on. If you're not getting rid of obligatory water loss, which is the minimum amount you must pee to get rid of body wastes that are building up in your bloodstream from metabolism. Cats that do this and humans that have this, they're going to get sick really quickly. And left untreated, they can die because the toxins are building up because they're not getting rid of the toxins. And eventually, left untreated, you're going to have multiple organ systems shut down. Doesn't sound good, does it? No. All right. So those are all not peeing, always an emergency. Come in now. All right. So same thing for humans. My explanation, because when you get to nursing school, they might talk about osmolality versus osmolarity. Even in our textbook, I think they talk about osmolality. It's just a semantics thing, definition. Osmolality is osmos of solute, what's dissolved in solvent, which is basically water in your urinary system or blood. Osmolarity is osmoles of solute per liter of solution, and I like liters versus kilograms, so that's just me. They get to nursing school and they say osmolality. It's kind of the same thing. All right, so don't let that throw you off. Okay, review. Hope you had this. You did get anatomy in the kidneys, right? You covered it. Okay, so you probably didn't go to the nephron level. Did anyone here in anatomy go to the nephron level of the kidney system? If you did, that's great. Then we'll be review for you. But if you didn't, that's really physiology. But your kidneys are paired organs. They're called retroperitoneal because in the peritoneal cavity, they're right up against the back. If people have kidney pain, like urinary stones, they're going to have debilitating pain in their back. And so you find that out. All right. Inside your kidneys, you have basically renal lobes. So these little pyramids right here marks, here's a lobe, here's a lobe, here's a lobe. And there's more lobes than that. They just couldn't fit them all in this image. And those lobes contain millions of nephrons, which we'll ultimately get to. And your adrenal glands, not shown here, well, maybe they're trying to show those little things, are sitting on top of each kidney. All right, we talked about the adrenal glands in the endocrine system. Then your kidneys are producing, filtering your blood and producing urine every hour of every day. And what gets ejected out of the kidneys is waste. And that's urine. And it's transported by the ureters, left and right, which then merge with the bladder. And the bladder, it's basically, a cyst, fluid-filled sac. That's got smooth muscle around it. In anatomy, did you learn the name of the muscle that basically lines the bladder? The detrusor? Anyway, so it's a sac that holds urine temporarily at different volumes depending on different people and body size. Some people, when the bladder stretches, It's got stretch receptors, and that'll signal your brain you got to pee, the urge to pee or micturate. And then the urine comes out through the urethra. And I said in males, the urethra is long and narrow, and women, the urethra is short and wide. Okay, so quick anatomy review. So depending on body size and people, some people, when their bladder fills only partially, they feel the urge to pee. Some people can let that sucker fill right up before they feel they need to pee. By the way, it is not healthy to retain urine. When you got the urge to pee, you probably should pee pretty soon. Holding on to that urine is actually not healthy for you. All right, so when you urinate, it's called micturation. That's the actual term for it. 6 to 8 times a day, depending if you're hydrated. Some of you, when we were in the kidney lab, you're saying, well, I never drink water during the day, you know? And so you don't pee very often because you're not well hydrated. That might be your normal. I used to be that. I used to have coffee in the morning, and maybe with dinner I'd have some tea or water or something like that. But I wasn't. Now I drink a lot, okay? It's very healthy to flush those kidneys out. So it's better to stay hydrated. I'm just telling you, especially if you're prone to, like ladies are, because the urethra is short and wide. It's easy for pathogens, bacteria to get up there and get into the urinary system and lead to urinary tract infections. Staying hydrated helps flush all that out. Okay, so, and we'll talk about if you pee more frequently than normal, which is a very common condition in people. Now, you didn't cover this in anatomy, but the anatomy of the bladder is it's got smooth muscle surrounding it. Do you have control over smooth muscle? No. Okay. You're like, well, if I don't have control of it, how can I pee when I want to go pee? It's the sphincter, that one of the 2 sphincters you have control over. The other one you don't. We'll talk about that. So the detrusor muscle is smooth muscle around the bladder, and when it contracts, it's going to squeeze urine out into the urethra. But there's a bouncer at the door of the urethra, and we'll talk about that. That could let urine out and might not let urine out. So the detrusor muscle is pretty important. Guess what? It's autonomic muscle. You don't have control over it. So that means it's regulated by sympathetic and parasympathetic control. Oh, she's going back there. Yes, I am. So rest and digest is a good time to go potty. Okay. Fight, flight, not a good time to stop and go potty if your life is in danger. All right, that'll get you killed. But if it's rest and digest, parasympathetic control, it's a good time to pee. What is the neurotransmitter that rules rest and digest? Acetylcholine. And its cholinergic receptor is muscarinic. I can't let that stuff go. Okay, so under influence of acetylcholine binding to its receptor, the detrusor will contract and squeeze urine into the urethra, and it's on its way to leaving the body. Under sympathetic stimulation, she did it. She introduced another beta adrenergic receptor. There's lots of them, by the way. I've only introduced you to a few. You might learn more in pharmacology. It's not a good time to go potty. You want to hold that urine in. So when epinephrine's in your bloodstream and it binds to beta 2 and beta 3 adrenergic receptors, the detrusor stays relaxed and urine just dribbles into it. All right, it's not a good time to go potty. Now, I think way back when we were covering this initially, someone said, well, why is it when you're scared and your life's in danger, you feel like you have to pee? That's because the increase in blood pressure and tension of your abdominal wall muscles puts pressure on the bladder. That's why. It's just kind of an artifact of the high blood pressure. Okay, so we've come back to it. I've introduced a new receptor, and I did it for a reason, and I'll get to that. So the urethra, there's 2 bouncers at the door. So this is the detrusor muscle. This is the first sphincter called the proximal sphincter. I know it's called internal as well, but I say proximal because proximal is anatomy directional language. Proximal means closer to a point. In this case, it's the sphincter that's closest to the bladder. You don't have control over the proximal sphincter. It's smooth muscle. It will be under control of parasympathetic and sympathetic control. The distal sphincter right here is skeletal muscle. You learn as a young child with potty training how to control that one. Okay, so in the male, the proximal sphincter is above the prostate, and below the prostate is the distal sphincter. So potty training involves the distal sphincter. And it takes a little while because kids come out and not all systems are fully engaged, right? And it's going to take them a while to learn to hold the urine and then to let it go when they're on the potty, right? And so that over time, you gain control of those muscles. But the proximal sphincter, you have no control over. So the proximal sphincter, don't memorize the nerves. I don't care about that. But I want you to know under sympathetic and parasympathetic control, what happens before I even bring it up. When the detrusor of the bladder contracts, it's pushing urine into the urethra. Now, the proximal sphincter, the thing you have no control over, can either relax and open up and allow the urine out, or contract and close off the urethra so the urine can't get out. Which do you think allows the urethra to open up and allow the urine out? Is going to be a sympathetic response or a parasympathetic response? It's going to be a parasympathetic. This is a good time to go pee. You have to think, what allows the urine out? The detrusor contracts to squeeze the urine into the urethra. Proximal sphincter has to relax to open up and allow the urine to pass. So the detrusor and sphincter muscles are doing different things. But if you stop and think, what would allow urine out? Detrusor contracts, proximal sphincter relaxes. Now, if it's sympathetic, the detrusor relaxes, so it's not squeezing urine into the urethra. Just as a safeguard, the bouncer, proximal sphincter, is going to clamp shut, so no urine can get out. Okay. All right. So if you stop and think about it, it makes sense. So parasympathetic control, good time to go potty, good time to get urine out. The detrusor muscle, based on acetylcholine, oops, lost my pen, and its muscarinic receptors will contract to squeeze that urine to the urethra. The proximal urethral sphincter will relax to allow urine out. Okay. The sympathetic would be the exact opposite. So in this case, not a good time. And notice I'm also bringing another one here. An alpha. So there's beta 2, beta 3, and alpha. All right. And there's multiple alphas, but I'm not getting into that. Not a good time to go potty. What has to occur to keep urine in? The detrusor muscle relaxes to allow filling with urine. It's not contracting, but to keep urine definitely from passing, the proximal sphincter will contract to not allow urine out. Let me distract you with something that'll get your attention. Sex. In males, arousal, sexual arousal is a cholinergic event. It's acetylcholine. It's a parasympathetic event. Ejaculation, however, is a sympathetic event. Okay. So if semen is on its way through the transport tubes, one of the tubes merges with the urethra. Now, reproductively, you don't want urine coming out the urethra when there's seminal fluid coming through, because the urine and with its acidity can kill the sperm. So what happens during ejaculation is the proximal sphincter clamps shut so that no urine can be going through when seminal fluid is going through. This is why after ejaculation, for some men, it takes a while to be able to pee, because you need time for that proximal urethral sphincter to relax again after that event. All right, did that get your attention? Okay. At least it explains why sympathetic clamps down that sphincter. So the distal sphincter is skeletal muscle, acetylcholine and nicotinic cholinergic receptors. You've had that enough to death this semester, right? Hopefully you'll always remember it. But pelvic floor muscles, which I don't know if you covered in anatomy, but an example of one is the pubococcygeus muscle. Don't worry about the nerve, just pelvic floor muscles. You can squeeze those. You learn to gain control of those. So when you have the urge to pee, you don't necessarily just wet your pants, okay? You can hold it long enough to get to a bathroom. Okay, so that's called the guarding reflexes, voluntary control of that distal sphincter. And that's when the kids go from the diapers to the pull-ups and then to the big boy and girl pants, right? Panties, when they can control it. What else do I want to say about that? No, I guess that's it. All right. Oh, and by the way, it is kind of normal. Sometimes some kids can have this control, gain this control relatively early on, and some kids, because their bodies are growing so rapidly, which means they filter more urine, take a little bit longer for this control. So sometimes kids wet the bed. I'm not talking 10 or 11. I'm talking if it takes them a little bit longer, it's not necessarily a thing. If you check with your pediatrician, it could just be because they're growing so rapidly, it's going to take them a little bit more time to gain control of that. Okay, so this is just some gifts to kind of bring home the parasympathetic in cool blue and the sympathetic in red. And I didn't include a link, but basically it's the detrusor muscle, okay? So if it's filling, it's a sympathetic thing because sympathetic makes the detrusor relax. If it's contracting like that, that's a parasympathetic thing. The detrusor contracts, all right? Now they're showing the proximal sphincter here and the distal sphincter here. This GIF is okay, but you can see when it contracts, the detrusor contracts, the proximal sphincter relaxes. And when this is relaxing, this is clamped shut. All right, but I think it's pretty straightforward. Now, bladder problems, so common. And I'll go over some of them. Of course, urinary tract infections, more common in women than men, doesn't mean men can't get it. Okay, so someone comes in and you're collecting the patient history and they say anything like this: it burns when I pee, and sometimes there's a little bit of blood in it. If it's a woman, are you having your menstrual flow right now? No, I'm 2 weeks away from that. It's not that. Okay, that's important. That's an important patient history because it could either be a urinary tract infection, which could cause both the pain and burning and the blood, especially if it's lower urinary tract, or it could be sexually transmitted infection. Either way, you got to get to the bottom of it and fix it. So urinary tract infections is basically infection usually starts in the urethra because that's where bacteria and stuff can get in. So based on the short, wide urethra, more common in women than men, not saying men can't get it. So urethritis, all right, is basically inflammation of the urethra. And if you get that as a patient history, you need to find out. You need to get a urine sample. You need to get a sexual history. Have you had unprotected sex? Any other things? Probably time for a pelvic exam. All right, because both problems, urinary tract infection or sexually transmitted infection, left untreated, you're going to have big problems. So if not treated, it can go up the urethra. It can actually go into the bladder. And now you've got problem. You've got bladder inflammation. Now it's called cystitis because a cistern, people don't have these anymore, unless you have a really old house, is basically a water containing device. All right, it's called a cistern. So the bladder is a fluid containing organ, so it's called a cyst. So cystitis is inflammation of the bladder. I've actually seen this in cats because of urinary tract problems, usually male cats, where they can't pee and their bladder becomes very inflamed because the toxins are building up. And chronic inflammation of the bladder can wear away the lining of the bladder. You can actually have problems with that. You can actually weaken your bladder. I've actually seen one cat with a bladder ruptured. Okay, so urinary tract infections got to be treated. If it's not treated, and now you have bladder pain and you're inflaming your bladder, that can go right up the ureters, right up to the kidneys. And then you're in big problems because you have an infection in your kidneys. You need your kidneys to function. If they're not functioning 2 or 3 days, you're a goner. Okay, so pyelonephritis is inflammation of the kidneys. And this is where it's bad. What have I taught you about, say, subdural hematomas and fluid trapped in confined spaces? It's bad, isn't it? That fluid builds up pressure, and that pressure moves outward and can compress and necrose soft tissue nearby. Your kidneys are producing urine every hour of every day. As urine is continuing to be produced, your kidneys, if they're inflamed, you have more pressure inside your kidneys, and that can cause damage to them, inflammation too. Now, if someone's got inflammation of the urethra, it could be so inflamed that it actually is bleeding. The blood that comes out will be kind of bright blood. That's lower urinary tract infection. If blood comes out and it's more dull red or blackish, that's old blood that's kind of clotted up. That could be a higher urinary tract infection, like it could be in the bladder or something higher than that. Either of those things is bad news and have to be treated. If an infection goes all the way into the kidneys, the person, it's not enough just to take tablets of antibiotics or maybe even IV antibiotics. They might have to actually inject antibiotics right into the bladder, and they can do that. They can take a long ass needle and go right into the bladder and get those antibiotics in there. They can also insert a Foley catheter. Anyone know what a Foley catheter is? You're going to learn it in nursing. You're going to become practiced at placing it in one of the sim models, the simulated human models that they have. Okay. Now, continue with some urinary problems. These are all very common. You're going to see them on the daily. Overactive bladder is where someone's detrusor muscle is overly stimulated. Even when the bladder's not full, they feel the urge to urinate. And so if you're getting up 6-8 times a night and you didn't have a beer bender the night before, because if you drink a lot of beer, you're going to be peeing throughout the night. But if that's not the case and they're peeing 6 to 8 times a night, that's not normal. Okay, that could be overactive bladder, usually more common in females. I'm not quite sure why, but there's a treatment for that, and it works on the receptors on the detrusor muscle. And so that's why they introduce all of those receptors. All right, so this is very common, and there's drugs to treat it. So overactive bladder treatments can come at the problem 2 ways, from the sympathetic versus the parasympathetic side. So oxybutynin, I'm giving the most common ones prescribed, is an acetylcholine blocker. Acetylcholine binding to muscarinic receptors on the bladder makes it contract and squeeze urine out. The problem with overactive bladder is you've got too much of that. So if you block acetylcholine, the detrusor muscle stays more relaxed and you don't pee. You don't feel the urge to pee. So that's one way, going at it from that angle. The other is to go after it from the sympathetic angle. The sympathetic promotes the detrusor to stay relaxed so urine doesn't come out. So mirabegron is a beta-3 adrenergic agonist. It promotes the sympathetic activity of the bladder, and that is to keep the bladder relaxed. All right. So all these receptor things are going to stay with you. In pharmacology, you got to know these things, all right? Because common treatments for a very common problem. While I'm thinking about it, as women age, especially if they've had multiple pregnancies or simply as they age, it just happens. You get a little bit of urinary incontinence, which I'm going to talk about. I'm going to talk about, because you have no control over your proximal sphincter. You do have control over your distal sphincter. All right, so we're going to talk about another, it might be the next slide. I can't remember because I didn't look at this before coming in. Okay, here it is. Perfect. Urinary incontinence. There's 2 forms. You can't hold your pee. So the first one is called urge incontinence. And I knew one person that had this when I was a vet tech. So here, after a strong urge to urinate, you completely lose control of your bladder. You get wet yourself. All right. I don't know all that's going on with that, but I do know one person who had it. And I used to have to go to her house every week as a vet tech to clean her dog's yeasty ears out. And he was not a nice dog. But she would never come out the house. She would just stand at the screen door. She never left her house. She couldn't come to the vet clinic, wouldn't come to the vet clinic because she had urge incontinence. And so at the slight urge to pee, she would lose her bladder. And that's very embarrassing if that happens in public. So she became a shut-in, and her house kind of smelled the pee a little bit, but it wasn't her fault, but it is a condition. If you run into it, what do? You wear adult diapers? That's really the only way I threw it. I do not know and didn't look up if there's treatments for it. There probably is. Now, the next one is very common. You're going to see it regularly. If a woman has gone through multiple pregnancies, she's taken on the weight of a growing fetus. The uterus is located right over the bladder. That's why later in stages of pregnancy, as the fetus gets bigger and heavier, it's pressing on the bladder and you feel the urge to pee multiple times a day. Am I right about that? Okay. That extra weight for the 9 months and everything that goes with it can weaken pelvic floor muscles. Just it can. Even if you haven't had kids, just as you age, those pelvic floor muscles can weaken. And when you jump, laugh, exercise, cough, sneeze, you'll be, whoop, I peed a little. All right. And it is so common, you're going to see it. You will, I guarantee it. Okay. It's completely normal. So common in women as they age or after pregnancy. It can happen in men too. All right. But they don't have, if they don't are never pregnant, then they don't have that putting stress on the pelvic floor. Now, does anyone know of a commonly prescribed, not drug, but thing a person can do to help strengthen those pelvic floor muscles so that that happens less? And you're smiling like you probably know what it is. Do you know what it is? Kegel. Excellent. Kegel exercise is to contract and relax pelvic floor muscles to strengthen them. And I think they even tell this to pregnant women, that after birth, got lots of responsibilities. But another thing is, if you want to reduce this stress incontinence, you're all going to go home later and probably do this now that it's funny. This is how you explain it to the patient. Okay, going to the bathroom. Okay, repeat. Clamp down your pelvic floor muscles and try to stop the urine stream. Clamp down. All right. And if you get the urine stream to stop, you have successfully contracted those muscles. And then you can relax and it'll pee more and then pee, stop. All right. And once you get good at, you're contracting these muscles, you can do it throughout the day. All right. You can be sitting in class, do Kegel exercise, no one knows. All right. But after a while, like any muscle, you're going to strengthen it and it can reduce this. All right. Like workouts, like things that work your lower body, like squats, and you're squeezing those muscles too. That can help. So trust me, as nurses, you'll be eventually training people in this exercise so they can lower that stress incontinence. So now you're laughing, but I guarantee you go home and try it. All right. So this is the urinary incontinence. Is a little bit of stress on the lower abdominal cavity can overwhelm that detrusor muscle and squeeze a little bit out. There are Depends and other things. They have those underwear that are very absorbent for menstrual flow, but people who have urinary incontinence can wear them too because it absorbs it so it doesn't wet your pants or whatever. There's all these products out there that you can buy to catch that urine. The other thing is try and treat it with Kegel exercise if that works. Okay, how are we doing? Doing good. Now, Foley catheter is inserted into the urethra. And there are certain reasons why you might want to insert a urinary catheter. So in the woman, the urethra is short and wide and it's easy to get in there, but there are multiple passageways. Don't be that one student who got into the nursing program who must have flunked this in anatomy that tried to put a Foley catheter into the vagina. The only thing that's going into the vagina is a speculum followed by a swab when you're doing a cervical or pap smear, okay? That goes there. That's the vaginal opening. That's the anus and the rectum. Doesn't go there either unless you're trying to get a poop sample or doing colonoscopy. Foley catheter goes in the urethra, which is the small opening that's anterior to the vagina. Don't make that mistake. Very embarrassing. All right. And it actually happened. Okay. And in the male, obviously inserted through the urethra, which is long and narrow. Now, I don't know this. I think I asked a student who did do some shadowing or work at the hospital, and they said that they don't sedate a patient when they're doing the, do you know?
When I had my C-section, they did the spinal first.
Okay.
So I could not feel the catheter.
Okay. And do you know, and I'll ask you, I know why they did a Foley catheter in you for the C-section, but do you know why they did the Foley catheter in you for the C-section?
Because I couldn't feel anything from like the waist back.
Yep.
So I didn't know if I pee. I couldn't feel my pee.
Yeah. So in your C-section, there's still going to be a lot of pressure on the inside because they're in there working, manipulating the baby and everything like that. But if you have a long surgical procedure, and I know this because I had a 2 or 3 hour one when I had my mastectomy, they don't want you to pee on the operating table and ruin the surgical field. They put a Foley catheter in so that urine goes into a bag and it keeps the field sterile. Yeah. Okay. So there's reasons for placing a Foley catheter. So here's some reasons, and you'll get more of this in nursing and get good at applying it. So if you want to get a sterile urine sample, what comes out through the urethra, because the urethra opens to the outside world, the lower urethral tract can have bacteria, yeast, whatever, okay? And so a voided sample, when you pee in a cup, some analyses, it doesn't matter, but if you need a sterile urine sample, it's not coming out the urethra. They get it from sticking a needle into the bladder, and that's very common. All right, it's going to be the physician or physician assistant doing it. But yeah, if you need to relieve urinary retention, someone is not peeing. Maybe they've got a urinary stone that's blocking their urethra. All right, and the bladder is stretching and becoming inflamed and stretching, and toxins are building up. You can actually do a bladder stick or a Foley catheter. And if the Foley catheter can get past the blockage, it can relieve the pressure on the bladder and get the urine out. Sometimes you won't be able to. If that stone is really wedged in there, you don't want to force it too much because you could actually poke a hole. But that is something you can do. If you can get a catheter in there, you can relieve the tension from the bladder. If you want to put medicine directly into the bladder, two ways: Foley catheter, thread that up there, put it in there, or the bladder stick. They usually prefer the Foley catheter because a bladder stick has to be kind of an emergency thing because that's poking a little hole in your bladder. All right. For incontinence, that's another thing, but I'll put here for add one for extended surgery. All right. Someone's going to be under the knife for a while and they need to keep that surgical field sterile. You don't want someone relieving their bladder during surgery. And if they're unconscious, it could happen. All right. Okay. How are we doing on time? We'll see what's next. We're getting close. Okay. I'll do some intro here. What comes after this? Yeah. More anatomy. You should know this. This is review. So here is your renal artery that's bringing the blood to the kidney to be filtered. What gets filtered and returned to the bloodstream can exit out the renal vein. So the renal cortex is this outer part right here. Put it here. All this outer part is the cortex. The inner part is the medulla. All right. And your nephrons extend from the cortex to the medulla. The nephron is the microscopic thing that looks like a snake. Here's the snake's head, and it twists, 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 goes down on a loop, and then twist, twist, twist again. Now, the calyces, basically the minor calyx is this. It joins with a renal pyramid. The urine is produced here in these microscopic things, and the urine collects in the minor calyx, which joins with the major calyx right here. And then that urine from major calyx goes down the ureter right there. So does that sound familiar from anatomy? You had those nice torso models. Okay, so that was probably the limit of what you learned. Maybe not all of you. The last thing we'll talk about, so I don't have to bring it up on Wednesday, is this vocabulary. So that's all I'm going to draw. Okay, I'm going to put AA here and EA here. This is the glomerulus of the nephron. And I've got plenty of images. Don't feel like you have to repeat this little chicken scratching. But arterial blood comes in through the renal artery, and the artery gets smaller and smaller and smaller until it becomes an afferent arteriole that brings the blood into the glomerulus of the nephron, the head of the snake. Okay. Just like in lab, that renal tube, that dialysis tube, your glomerulus has pores of thick size. Small things are getting through, lots of water. Big things don't. Big things get kicked out or exit out of the efferent arteriole. Blood cells and large molecules like starches and things like that can't make it through. They get kicked out. If you have things that are retained in the kidneys, they return to the bloodstream by peritubular capillaries that merge with your renal vein and get that stuff back into your bloodstream. So when I pick up on Wednesday, I'll certainly be using this vocabulary and I'll introduce you to these right here. All right, I'll see some of you in lab today. Last lab, woo!